Hello and welcome to this VetLit podcast. This is a follow-up podcast to one on rivaroxaban and apixaban that we made with our guests Alex Lynch and Rob Goggs. And what we've done is collate some burning questions of what listeners want to know on all things coagulatory, on heparin, on clopidogrel, arterial thromboemboli, pulmonary thromboemboli, you name it, it's all on the table. It was too good an opportunity to miss, so we welcome back Dr. Goggs and Dr. Lynch for our burning clinical questions. Dr. Alex Lynch is an associate professor in emergency and critical care at North Carolina State University College of Veterinary Medicine. And Dr. Rob Goggs is an associate professor in emergency and critical care at Cornell University College of Veterinary Medicine. Now, firstly, thank you both again for joining us and for answering all our questions. It's a fantastic chance to get some really useful insights. So thank you.
Yeah, you're very welcome.
Yeah, good to be here. Thank you.
Perhaps a tiny bit of background here would help, but in 2019 came the curative guidelines, consensus statements on the rational use of antithrombotics in veterinary critical care. So providing evidence bases for consensus recommendations on questions such as, in what conditions is thromboprophylaxis recommended? Answer, IMHA, protein losing nephropathy, probably heartworm too, those kind of things. Then we should consider them in disease states such as pancreatic necrosis, neoplasia, sepsis, but perhaps only where hypercoagulability is also documented or other risk factors exist. That's a really, in a nutshell, intro. But plenty of other recommendations covering antithrombotic protocols and discontinuation, for example. They also identified a number of knowledge gaps, so setting up for future studies to be performed. And aside from being major contributors on multiple domains of the curative guidelines, Rob and Alex themselves seem to be filling in the knowledge gaps themselves. So they're amazing guests to have on at this stage. My opening question for you both is, should we be more proactive with thromboprophylaxis in general?
Possibly. I think we have to really weigh up the benefits and risks in the populations we're looking at. If we look at the curative guidelines and our clinical experience, there's that list of situations we know are, supported by the evidence. We've got good clinical background, good clinical experience to suggest it's warranted. And what I struggle with sometimes, I think, is figuring out in those diseases that we haven't necessarily identified as being a high risk population,
Mm.
separating who within that risk might, within that disease could be a high risk. So,
Mhm.
like you say, does every pancreatitis case need thromboprophylaxis? Depends on the presentation, perhaps. If it's a dog that really has a self-limiting gastroenteritis sort of presentation, maybe not. But then we've all treated the dogs that are incredibly inflamed, really sick, getting multiple treatments in our ICU, have long stay venous catheters, and that I think is a different population then. So if we had a way to stratify or kind of weed out the cases that are higher risk within those muddier diseases, then I think being more proactive with thromboprophylaxis for those, I think actually is warranted.
Yeah, those are the ones that really interest me, right? But it's the cases that bug me are the ones that are, for example, you got a septic dog, it's a bit older, it's taken a bit longer to recover,
Mhm.
it's maybe it's had an aspiration event a few days later, it's lingering in your ICU, it's recumbent. Recommendations would probably say to consider that. And I think it's that population of dogs that I've only got regrets about not anticoagulating. I don't think I've ever actually regretted anticoagulating something too much. Maybe I've not been too aggressive enough. But that's the situation I find myself in. And I wonder if there are situations in which we should just be broadly more content with the safety profile of these drugs and yeah, to hand them out like Smarties. How about that?
So, I mean, my answer to the kind of original question is, if we preface it by saying first do no harm, then I think the short answer to should we be more proactive is probably yes. I think there have been more instances where I've considered it, decided against it, and then regretted that decision than has occurred the other way around.
Yeah.
I do think that Alex makes a really good point that the three of us, our practice types are definitely distinct from other areas of veterinary medicine, right?
Yeah.
We're veterinary emergency and critical care specialists, and our patient populations are very sick. They are the kind of most severely affected examples of all of these different disease processes. And so the answer is more likely to be yes, be proactive in the patient populations that we manage. And Alex makes a really good point that the sort of relatively stable patient being managed in primary care with a gastroenteropathy and some mild pancreatic inflammation, that's not the patient that urgently warrants thromboprophylaxis. And there's probably a greater likelihood of harm in a patient population like that than in the patient population that we manage, where we also have the opportunity to be more proactive about monitoring, the effects of the drug. Those patients are already being repeatedly reevaluated on a relatively short time scale, and so we're more likely to identify, benefit and harm in a means to actually do something about it. So, generally speaking, yes, but I think pick your battles and identify the patients where you really feel like there's a signal. It's warranted in this case as a subset of the septic patients or a subset of the cancer patients, and treat appropriately. But it shouldn't be a blanket. Everyone with pancreatitis gets thromboprophylaxis.
Yeah. That's pretty reassuring to know, though, that in these settings, similar patient populations between the three of us, though, you have the same feelings, same regrets. That's quite valuable to know. Another question. So, what would be your priority knowledge gaps from the curative guidelines? So, they've identified a whole host of situations that we need to know more about. What are your priorities, or what are at the top of your own to-do list? I suspect you've got a couple up your sleeve anyway. So, tell me what the future looks like.
Well, I think on the back of our apixaban, rivaroxaban sort of healthy dog study, trying to see where those fit into clinical cases. Can they replace traditional therapies? Are they part of the spectrum of how we treat these cases? The thing that kind of springs to mind is, would I feel really excited about giving an oral anticoagulant to a anorectic, really inflamed, really sick IMHA dog on day one, or could I get that dog through with a heparin injectable kind of plan for a few days and then transition that dog? So that's where the kind of direct oral anticoagulants kind of fit into that mix is an interesting question to me. As well as I think the, expanding extracorporeal techniques that, are sort of becoming more and more commonplace in your sort of secondary and tertiary sort of level care places is, what's our plan for those dogs that maybe are anticoagulated half the day anyway? If they're having a long session, what do we do? What do we do on the other part of their day? I think that's actually an interesting question to me too.
Yeah. And when they've got a great big central venous catheter in, which is
Right.
thromboting
Yeah.
despite all of your efforts. Yeah.
Yeah.
Okay.
So I have like a laundry list, like an entire career of stuff. So I was thinking about this, in preparation for today, and I feel like there's a whole bunch of little sort of subfields where some additional study would be helpful. Like, I think there are some really basic things about cell biology, about the coagulation system that we don't understand, or haven't fully investigated. So we assume we know what's on the outside of a dog platelet, but we probably have some of it wrong. And that may influence the potential efficacy of some of the drugs that we might want to use. We don't really understand what the endothelium's doing. Like, how recently do we recognize that we'd missed the endothelial glycocalyx had been there for a while, and we just spotted it, right? So there are these things that I think are on the basic end that would really help us to do more good and less harm, and to target our drug therapies more effectively. I think to that end as well, better understanding of things like the role of netosis, fibrinolytic disorders, as they pertain to thrombotic risk. I think there's a huge area of focus, across medicine and veterinary medicine in those fields, but they may offer us novel insights, novel risk factors, and potentially even novel therapeutic avenues that we haven't explored that are separate from the kind of classic, anticoagulant, antiplatelet approaches. I feel like there's still plenty of drugs that we don't fully understand the PK/PD of. That we have the isolated study of this drug or one study of that in 6 beagles. And repetition is really crucial. Not every dog population or every cat population will behave the same. And it's dangerous to extrapolate from 6 beagles to all of dog kind. And we, I think, have a number of medications that offer potential benefits based on the human literature that we really haven't touched at all. There are some additional oral antiplatelet agents that also act through the P2Y12 receptor, prasugrel, ticagrelor, that potentially might offer additional benefit. There are the other class of direct oral anticoagulants. So we talked about the 10A inhibitors, but there are also the direct thrombin inhibitors, things like dabigatran that might be an option. So there's plenty of basic PK/PD stuff to do across a whole range of things. And then that's even before we get to actual clinical trials, because we're really lacking with good patient identification, like clear indication that you fit into this study category. It's easy with feline arterial thromboembolism, like we can definitely make a diagnosis that's fairly positive of that. But how many cases have suspected pulmonary embolism have we encountered where trying to make a definitive diagnosis is hard, but you need that in order to enroll that patient in a clinical trial, and you need that as the end point to say, the thrombus resolved or we were able to prevent a thrombus. We need to be able to definitively make that diagnosis, and I think that's one of our limitations.
Yeah.
And you can imagine in all of these different populations where we said you should either consider it or it's indicated, we haven't optimized individual drugs. We haven't optimized what drug strategy, like this drug or that drug, or is the combination better? There's, like I said, a career's worth of stuff to do. And it's just trying to find, I think, the most relevant, most important questions to try and address first. The highest risk patient populations, which is, rightly so, there's been a lot of focus on feline arterial thromboembolism because it's such a devastating complication. So that's a great avenue to explore, and there's still plenty of work to do there. But we shouldn't neglect the possibility that actually we might be able to help a whole bunch of cancer patients by some targeted additional therapy.
Great.
But I like the idea of the dual therapy questions too, because at least sort of in the US, platelet inhibitors are financially much more affordable for most people. Whereas the direct oral anticoagulants are very expensive. So if we could understand, is there a clear advantage of using both? Do we have a surge of risk, for the first 2, 3, 4 weeks of a disease process where you could rationalize spending the money on both drugs for a while and then perhaps cruising on clopidogrel afterwards? That I think would be practically very helpful to figure out too.
There's a few comments there that might send us down the next question, which is the SUPERCAT study. So why did the recent SUPERCAT study result in, do you think, no difference between clopidogrel and rivaroxaban? And should we evaluate that with a prospective style trial combining those two treatments? Because people are using that approach already, right? Well, it's what happens in veterinary, isn't it? Things are done clinically before they're justified with an evidence base, perhaps. Debate.
Exactly. And I think I'm lucky. One of my colleagues, Ronald Lee, does a lot of feline platelet investigation, and Rob is very well versed in the platelet too. But it does make me wonder how much of an interplay there is in the mechanisms of thrombosis in cats with cardiomyopathy that develop ATE. If we can hit it from several directions and it seems to be equivalent, then I think it's a complex pathophysiology too. So maybe there's multiple right ways to get the effect we want. But I will say my knowledge of platelet biology in comparison to Rob spent a lot of time work thinking about platelets, so I'll let him weigh in if he agrees or disagrees.
Yeah, so I think the answer to your question is there's probably plenty of reasons why we might have found that there was no difference between the two. I think the finding of no difference doesn't mean there is no difference. You could be super skeptical and say, well, neither drug did anything, and that's why we didn't find a difference. I don't feel like that's probably the correct answer because the outcomes for these patients were comparable to the outcomes from the clopidogrel only arm from FATCAT. And that was superior to aspirin. So I think it suggests that they are doing something. In this study design, in this patient population, with this number of cats enrolled, they were not able to observe a difference. It's entirely possible that had there been more patients or a different sort of set of patients within the disease process enrolled, or if we'd spent more time and energy optimizing one of the drug dosing regimens, is there potential for a difference there? Did we just miss it? Is it a type 2 error? That's possible. I think looking at the kind of confidence intervals can help with that to say, what's the likelihood of a genuine difference? How feasible is it to separate those populations, and how many additional cats would we need? I think if there is a type 2 error, the difference is probably small. And so, this gets into those statistical questions of superiority, equivalence, and non-inferiority, which is probably another session for you, Simon. I think here you can probably use them somewhat interchangeably in this patient population. That obviously assumes that we're all talking about the same set of cats, because to get into SUPERCAT, to get into FATCAT, you had to survive your initial ATE event. And so can you just blanket apply this to the next cat you see with ATE? Possibly, right? But not without some thought, because we're actually automatically excluding some of those patients who might be the most severely affected, or where there isn't the motivation or means to continue to provide care. So there are always caveats, right? That the headline says no difference, but delve a little deeper and sometimes a different picture or other potential pictures emerge.
On that question of the naive cat, the cat that you identify on a screening echo early in their disease course, way before an ATE forms, that would be an interesting population to look at too. The haven't had a clot yet. Sort of what does that look like for those?
Yeah. It's I find it interesting when you have a moment to sort of reflect on these cats. It's pretty amazing how much scope there is still for improving, welfare and outcomes in this population of cats that, 10 years ago, for example, the vast majority just are euthanized on presentation, right? And sometimes we forget, I don't know if you agree or not, sometimes we forget that there is this whole, Virchow's triad, right? And we're very broadly treating the hypercoagulability component of that triad. But actually, yeah, there's this whole endothelial dysfunction, there's a whole blood stasis perspective, which we're not really doing anything about. And who knows? I love thinking about in 10, 20, 30 years' time, maybe we'll actually have solutions to more of those components of the triad.
Yeah, it's to be hoped. Yeah, I think going back to something that Alex said about the crossover effect, I think what you just said, Simon, about Virchow's triad being multiple components, that may be part of the reason why we do have some crossover efficacy. And there are similar data in the human field where patients who develop a venous thrombotic risk, so sepsis is the classic example, who come into the hospital already receiving an antiplatelet agent, they tend to do better than the people who get sepsis who are not on an antiplatelet agent. So there's definitely this crossover, and it may be that what's happening for the cats just getting an antiplatelet agent is we're diminishing thrombus stability under flow conditions, that they need that ongoing ATP, ADP signaling to maintain activation. And if we blanket kind of suppress that, the platelets are less able to contribute to the ongoing thrombus development. But if we're using an anticoagulant, maybe what we're primarily targeting there is reducing the influence of that sort of spontaneous echo contrast, right? The kind of swirling, not very rapidly moving flow. Maybe that's where the rivaroxaban is having its effect. And so potentially that might argue for a combination therapy being more effective. It probably also increases your bleeding risk, right? Because now you're attacking the system from both sides. And I think, we've talked about, do we need a trial or an investigation specifically of single agent versus dual therapy? To design a trial like that, you need equipoise, right? There needs to be a genuine lack of consensus, a real kind of, we don't know what the best option is, in order to justify a trial of single agent rivaroxaban against dual antiplatelet anticoagulant therapy, or whatever your trial design is. And if folks are already moving towards dual therapy for their most severely affected patients, then is there equipoise?
Yeah. Are you going to achieve it even if you set out to do it?
Yeah, because you need to be able to recruit a sizable number of cats in order to answer that question. And they already struggled with SUPERCAT. And one of the comments they make is that actually, in the time it took them to enroll about half of their original sample size, I think they wanted 90 cats originally. And in the time frame it took them to do the study, people's practice had started to shift.
Yeah.
And so it was actually more difficult then to convince everyone to enroll patients in what some might have considered to be suboptimal single agent therapy.
So then, is it provocative to ask what you do treat a cat with a diagnosed ATE being discharged from hospital with?
I think we've moved into the trend of dual therapy
Yeah.
quite regularly.
Yeah.
I will admit, long term, for what the sustainability of that plan for people is, I don't know. So maybe they do revert after a month or so, maybe to just one or the other. But yeah, at discharge, dual therapy is common.
Yeah. Thinking about the curative guidelines, are there any specific situations in which you find yourselves repeatedly or actually prescribing or wanting to prescribe antithrombotics beyond what's recommended?
I would say in my practice, severe inflammation, so sepsis, really bad trauma, once they're past the bleeding, or hemostasis is achieved from that perspective, or those bad pancreatitis cases that we talked about. I think we have a pretty reliable track record of anticoagulating those.
Yeah.
What I think populations that are maybes, and perhaps we talk about but don't always do, might be your post-op splenic mass dog, where we've got, evidence that some of those dogs will get thrombosis post-operatively in the portal system. There's some data out there kind of suggesting they do become hypercoagulable for a while afterwards, but that I think is a harder population for us to get consensus on doing post-operative anticoagulation. I think that's been a harder nut to crack, as it were, compared to your septic dog in ICU. But it does raise the question of how long do we do it for? That I think is often a conversation. It's a septic dog who's made it, is going home, and that question of it's going home, do we need to continue this or
Yeah.
not?
Yeah, that's nice to hear because I don't think we are that aggressive. I like the idea that we're looking at these populations of dogs where the recommendations say consider, and your version of consider in pancreatic necrosis and really bad trauma results in giving, and I think we're still considering. So I like the idea of, I like to hear that you're doing that, because yeah, I'm wanting to be a bit more proactive in those cases. Yeah.
And there may be some clinical data that we've got to justify our argument a little more. Maybe we've got C-reactive protein on these cases, and it's clear they're really inflamed. The inflammation is present, it's not going away, and their platelet counts are dropping some, and I could argue it's consumptive. There might be little bits of clinical data out there that make me more confident, perhaps, in making that call.
Yeah.
But I agree that it is something that once you do more of them, I think you feel more confident, and then it's easier to make those calls.
Yeah. Yeah, definitely.
Yeah, I think I would echo those. I feel like Alex and I are in two very fortunate positions to have the benefit of comprehensive coagulation testing.
Yeah.
That it gives you perhaps clearer insight into what's happening, more confidence to be able to manage those cases and to do dose adjustments if you feel that's necessary or appropriate, versus a situation where you're flying a little more blind, right? Where you don't have access to that same level of testing, or you're managing a patient population where there are financial limitations. The testing's available, but you can't spend the money in that way. So I think that spoils us and gives us an opportunity to be more aggressive because we have objective measurements and some I wouldn't call it a safety net, but some feeling like, okay, I have the ability to make adjustments if I need to.
Yeah.
The only other kind of comment I would make about the curative guidelines is that they really are just that. They're intended to provide a systematic evidence review to back up people's decision making, but then they're never intended to replace your clinical judgment.
Yeah.
That I think if there is a good rationale, even in one of those conditions where we say consider, or where we say there just isn't enough evidence, if in your individual patient, based on factors that are germane to that particular case and that client, that warrant intervention, that's fine. I don't think
Yeah.
that's outside the guidelines. I would say we don't typically prescribe things where the guidelines say don't do it.
Mhm.
But there is plenty of those cases where you've got perhaps additive minor risk factors.
Yeah.
Patient with one of those kind of long stay central venous catheters who has an inflammatory disease, who's on glucocorticoids. And now we're like, well, any of those on their own wouldn't be enough. But potentially the combination and sometimes combined with some lab work allows us to say, actually, on balance, I think a short-term intervention while we manage their significant inflammatory disease is warranted. And then it's like antimicrobials. There needs to be a constant reevaluation as to whether a patient needs antimicrobials. Do they need thromboprophylaxis? Once the risk factor has gone, the sepsis case that Alex mentioned that's being discharged, their risk factor really has gone. Unless you have, some underlying disease process that perhaps precipitated the septic event. If the sepsis was, perforated foreign body intestine, then you've cut out the bit of intestine, removed the foreign body, mopped up the abdomen, killed the bacteria. Dog looks great. Doesn't need thromboprophylaxis, in my opinion.
Yeah. Probably doesn't need antibiotics either.
That's probably accurate, yes.
And perhaps this is a good place to pause. To keep these bite-sized or to allow some inter-podcast revision, we've divided these into two parts. This is the end of part 1, and part 2 will be out very soon, so do join us again when we'll discuss viscoelastic testing and hyperfibrinolysis. And until then, I hope you can find an interesting article to read via the website or our email updates. And bye-bye for now.